Like in every general dentistry practice, I also place implants in my office. And when I compare my complex cases, and I say, I call complex cases my overdenture cases, maybe 4 implants and an overdenture, or my hybrid cases in my office, and I compare them to my simple cases. My simple cases are my single tooth replacement using dental implants. And when I look at the numbers, 7 out of 10 cases that I do in my office are those single implants. So keep that in mind, because most likely in your practice, you're doing the same thing. The majority of your cases are those single implant cases. Now, these can also be very challenging because it really depends on the location of the tooth. If it's right in front of the mouth, if it's a central incisor, a maxillary central incisor, and the smile line of your patient is very high, that's going to be a very challenging case. It's going to demand a lot of planning behind it. And that's what this video is going to be about. It's going to be how do I plan, execute, and restore those single implants in my office. So my first step for the great majority of things that I do in my practice is always going to be clinical photos. And these photos are going to be, retracted view photos, always a small photo if it's in the aesthetic zone. But if it's not in the aesthetic zone, I'm going to do occlusal shots of the area that I'm going to be working on. And in those occlusal shots, what I'm looking for is literally tissue. I'm looking, is there any bone resorptions that I need to be aware of? Is there enough keratinized tissue? Where's the mucogingival line? Information like that I really want to look into when I'm planning my cases. And that's something that I just don't want to look into my patient's mouth. I want to register that through a photo, so that when I'm planning my cases with the CBCT and all the other tools that I need to have, I'm sure that I have this photo, this static image of the patient's mouth, so that I can remind myself, what is this site going to look like, and kind of imagine and plan in my head, okay, how am I going to go about executing this surgical procedure? So clinical photos, extremely, extremely important. When it comes to the surgical planning and the guides that I'm going to select for my surgery, it all comes down to the actual surgical site that I'm going to be working on. And what am I referring with this is specifically to 2 options that you're going to have. It's either going to be an immediate extraction implant, and when I have an immediate extraction implant case, I'm not going to use a surgical guide. I'm going to extract the tooth, and the actual alveolus that is available for me there, that's the guide that I'm going to be using. That's really the direction that I'm going to try to follow in order for me to place that final implant. And then I'll share with you a case like this towards the end of this video. But when am I going to use a fully guided protocol, which is what I think we should all be doing if there is an edentulous site or in our more complex cases. But let's talk about an edentulous site where you're going to be replacing 1 tooth, or maybe sometimes even 2 neighboring teeth. There's a couple of things that you need to understand and that you need to answer prior to you deciding, am I going to use a fully guided protocol? The number one reason why I would recommend one, you're going to be able to control very, very well the distance between that implant and your neighboring teeth and those single implant cases. You're also going to be able to fully control the depth of your implant. Now, don't forget that if you want to accomplish a very nice and natural emergence profile, your implant is going to have to be below that crest, maybe a couple of millimeters. So you want to make sure that you control that depth, because in many clinical situations, mainly when you're working the posterior maxilla, you're going to have that sinus that you're going to have to try to avoid getting into, or that you're going to have to maybe elevate the sinus internally or externally, and you're going to have to plan that ahead of time before you decide of placing that implant. But let's look at a case where you don't need to get into the sinus and you want to actually prevent that. Well, that's when a fully guided surgical protocol is going to be extremely beneficial, because again, you're going to have an automatic stop on the depth of your preparation. So just to summarize, you're going to have 2 options based on your cases. When do I decide not to use a guide? On 2 options, or 2 clinical options. Number 1, my immediate implants. I'm going to have that previous tooth that I extract, that socket is going to be my guide. or the cases where I have enough, I have an edentulous side, but with enough bone height and bone width and two natural teeth on the side. If I have that really straightforward case, you can just hand guide that drilling protocol to place your implant in the perfect location. But if for whatever reason your experience level is not at that point at this moment in your clinical practice, then please always decide to go with a fully guided protocol, even if it's a single tooth. And if it's going to be two neighboring teeth, I highly recommend that fully guided protocol, because it's going to give you the right angulation, the perfect location, the right axis location of both of those implants, and most importantly, it's going to help you guide the full depth of your implant so that you have that more natural emergence profile. When it comes down to sequential drilling, every single system out there is going to be color coded. In my office, I use a specific brand of implants. Maybe it's different than the one that you use in your practice, but I don't think that the color coding is going to be any different. You know, they all today have that color coding, which makes it a lot easier for us to kind of just simply view and kind of follow those color codes to the diameter and the depth of the implant that we are gonna, we're gonna be using for a specific clinical case. So the most important thing that I want you to know is that first drill. When I'm teaching younger dentists how to do this, and I continue doing this every single day, even though I've been doing it for many, many years, I like creating for my single implant sites, I like creating something called the bleeding point. And that bleeding point, I actually perform it with the lancet drill, which is the thinnest and sharpest drill that you're gonna have in your surgical kit. Now, I like doing what I call that bleeding point. If you're using a guided surgical protocol, you can go through that guided guide and just create a little dimple or just a stab, if you want to call it that way, the tissue, and then go maybe 1 to 2 millimeters within the bone. All you're trying to accomplish is creating that bleeding point. And I do this before I flap, so that when you flap, you can actually visualize exactly where you nick that bone. Now, if you're using a more analog protocol, if you're doing a free-handed surgical protocol, that is even more helpful, because again, you're gonna see that bleeding point through the tissue, and you're also gonna see that bleeding point once you flap the tissue into the bone. And it's gonna be a lot easier for you to continue that initial drilling with that lancet drill and go to the depth that you're trying to accomplish. Either 8, 10, 11.5, 13 millimeters, whatever the length of the implant that you're gonna use that's how deep you're gonna go in that initial drilling. After that, all you have to do is just follow your drilling protocol based on the system that you're using. Here you can see that I'm going to use, after the lancet drill, I'm going to go to the 2 millimeter drill, and then I'm going to go to the 3.5 if a 3.5 millimeter implant is the one that I'm going to be using. If it's a 5 millimeter drill, then I'm just going to follow the colors. I'm going to just follow the lines that take me all the way from that lancet drill to the 5 millimeter diameter implant. And then once I select that implant, the only other thing that I got to think about, at least for the system that I'm using, is the quality of the bone. Is it a soft bone or is it a hard cortical bone? If it's a soft bone, I'm going to stop in the drill for soft bone. If it's a more cortical bone, if it's a harder bone, I'm going to follow the drill. I'm going to use a second drill, which is a +5 drill in my system, that is going to just increase a little bit the diameter of that osteotomy, so that it makes it a lot easier for my implant to be drilled all the way down to the full depth of my preparation. So again, all this has to do with your implant system, and I'm sure that today all the implant systems are very similar in this regards. Once you have completed your sequential drilling and you're ready to now place your implant, there's two ways that you can do this. Either you're going to drill it in with your motor, and normally that's the way that I like starting. I just use my motor, I put it at maybe 30 to 40 RPM, I increase the torque maybe to 30 to 35, and then I just start drilling the implant into the implant site. And I'm gonna obviously use the carrier, and you're gonna have this carrier that is a latch type of carrier that you connect to your implant. Once this is connected, and normally there's a securing mechanism that once you attach that tool to the implant is not going to go anywhere. It's not going to fall out of that tool, and it's going to be very easy for you to take it to that osteotomy that you just recently prepared. And then all I have to do is just start, drilling that implant into that socket. Now, the implant is going to stop drilling once you get to that 30 to 35 newtons per centimeter of initial torque. And once that happens, you're going to have to retrieve the motor, and now the rest of the insertion should be completed by hand. And there's a separate tool that goes in your torque wrench that you then connect to the implant and start inserting your implant by hand at this point. By using this torque wrench, it's also going to allow you to see what is the final torque that you are gaining at the insertion of your implant. And this is crucial because this is going to give you the answer to a simple question. Am I able to immediately load this implant? And if you want to immediately load, my recommendation is to be around 50 to maybe 70 newtons. Anything less than 50 in my office is not going to be immediately loaded. I'm going to probably most likely place just a healing abutment, and I'm going to wait a couple of months based on that primary stability that I accomplished in my patient while I was sitting down or placing that implant. Now this again may be different in your office. You may use a different protocol or a different approach, which is completely okay and understandable. This is just the way that I do it in my practice. I want to make sure that I have high torque insertion if I want to load that implant immediately at the day of implant placement. So the emergence profile for the final restoration on an implant site can be managed in two different ways. The great majority of dentists just use a regular healing cap, and they insert that healing cap, they screw the healing cap into the implant at the moment of implant placement. That would then allow the tissue to heal around that healing abutment, and would have no need, for the dentist to go back and do a second stage surgery and remove any healing caps. So that's the benefit of using a healing abutment. Now, you can also do what we call a customized healing abutment. Now, the customized healing abutment, the benefit of the customized healing abutment compared to just a stock healing abutment is that now you're going to have the ideal emergence profile for your implant, starting to work on that the day of implant placement. So right after the implant is placed, you insert this customized healing abutment, and you suture around the customized healing abutment. Again, this is going to now allow the tissue to heal in that ideal shape and form based out of the tooth that you're trying to restore. Now, can you fabricate a custom healing abutment, after the period, the healing period that you would want to wait after implant placement? And the answer to that question is yes. The only downside to that is that it's just one more step. Now, I do that many times in my practice. Sometimes the day of implant placement, I just use a regular healing abutment, and then 15 days prior to me to make a final impression, I may add some composite to the healing abutment, and with that I'm going to modify the shape or the contours of the tissue around my implant. Now, one thing that I'm doing today in my practice is that I'm using PTFE healing abutments, which are these plastic type of healing abutments that the composite bonds to easily. Because if you're using metal healing abutments, the composite doesn't bond that well to metal, and it's going to disconnect, and you're going to see that you're going to get some bacterial contamination of the composite because it's now separated from that healing abutment, and it will start spinning. And if you want to try to accomplish a specific shape, and now your healing or your customized healing abutment is spinning, that's going to definitely affect the shape of the tissue around your implant. So that's the reason why I'm using the PTFE type of healing abutments today, because composite can bond to it very, very easily. So once you have completed the customized healing abutment, and you're ready to restore, so now you have the ideal emergence profile. All you have to do right after that is, today in my practice, obviously we're just using a scan body, and we're going to scan. Initially, my first scan is going to be with the actual customized healing abutment in the patient's mouth. And I just go ahead and scan the neighboring teeth, and I normally do full scan full arch scan, even if it's a single implant, just because I feel that it's a lot easier for the lab to, to just to articulate these models. So I do a full, let's say that I'm placing I don't know, an implant on site number 5. I'm going to do a full scan of the maxillary arch, and I'm going to scan that that customized healing abutment initially. Once I do that, I remove the customized healing abutment, I place my scan body, and now I'm going to scan my scan body and the tissue around the scan body. And that's really important so that the lab can see, okay, what is the shape of that tissue without the healing abutment that they're going to have to use, so that when they're designing that emergence profile keeps the tissue at the right location that you have accomplished and you have worked so hard to create using your customized healing abutment. And once you do that and you get your final restoration, if the design of the final restoration is correct, you should see maybe a little bit of blanching of that tissue. That crown should support that tissue. And normally what I like doing is I like using a customized abutment, implant crown abutment, and then I just have the lab cement the crown on top of that abutment. You can also use a UCLA type of abutment, and they can create that emergence profile for you. I like using a custom abutment so that then they cement the crown, because I feel like that's going to be a lot harder for these two pieces to separate. I have had some UCLA type of abutments kind of separate because they were not bonded well in the lab, and it just creates a real problem later, because you got it now rebonded chair side, which takes time, and you have to have the right material, and you have to use an ideal technique for that. So I like just to use a customized healing abutment, a crown. I have the lab bond this together, create an access hole so that I can go ahead and then screw retain this cemented crown on that custom abutment. That custom abutment is going to give you the support for the tissue that surrounds your implant, giving you the ideal emergence profile and making this tooth look very natural, like it literally comes out of the tissue, just like natural teeth do. In this portion of the video, I'm going to share with you 2 cases that are going to serve as an example of what we've reviewed here. Not only the implant placement and the tissue contouring, but also the delivery, or the final delivery of the restoration. Thanks for watching. If you have enjoyed this video, please make sure to subscribe to our channel. This way you're going to get instant notifications every time we upload a new video.